Good morning. It is Monday, June 2nd, 7:50 a.m. I just did my first night shift back on the north side, which is less acuity patients. I was with a different preceptor tonight because the charge nurses were not aware that I was supposed to be back on the north side, getting familiar with the lower acuity patients and working on time management. So I was partnered with somebody else instead of just having two nurses change their assignment. The two nurses being my preceptor and a nurse that was on the north side. It kind of interrupts like the flow of orientation because when you're jumping from preceptor to preceptor, the preceptor you're working with temporarily doesn't really know like where you're at unless you can effectively communicate what it is that you've been able to do independently and what it is that you still need to work on. So I feel like I've been effectively communicating that while it is important to understand how to take care of high acuity patients, we have been requesting high acuity assignments and we just don't get appropriate assignments based on the phases of orientation where I'm at. And so I guess what ended up happening is because I wasn't getting those high acuity patients in the phases of orientation that I was in, it kind of like put me back. So now that I'm requesting lower acuity patients, more patients in my assignment, my night shift preceptors don't feel that I've taken care of high acuity patients enough. And they believe, along with the educators, that I need to extend my orientation. And I feel that if I were to extend my orientation, it would have to be on the less acuity side, managing 3 patients, because when I managed more than 2 patients, it was when I was a tech, not a nurse. And so all I know is how to take care of 2 high acuity patients. And yes, it's a new specialty, but at the same time management is key. So if I have 3 high acuity patients, meaning that they are difficult feeders or they are on a little bit of respiratory support, I feel like that takes a little bit more priority over taking care of 2 high acuity patients, or sometimes even 1 high acuity patient. I feel like I've gotten a pretty decent exposure based on like the patient census, but unfortunately I don't think my preceptor and my educator and myself are on the same page. So I just feel like this general explanation is very important when it comes to reminding ourselves that you need to advocate for yourself what it is that you don't feel comfortable with. That also goes to show that there is some concerns with like floating on our unit. When our nurses are floating, they're not getting what they feel is a safe assignment for themselves. And some nurses do advocate for themselves and speak up, and then others are too maybe like timid or shy and they don't speak up for themselves. So it's super important to remind yourself that this is your license at the end of the day, and if something does happen to your patient, like it falls back on you, not the charge nurse or your preceptor who, you know, precepted you while you were on orientation. Once you're off orientation, like it's all on you. So I was reminded that once I'm off orientation, like that's it, which I understand. Once you're off orientation, you can't go backwards, but I'm more comfortable prioritizing less high acuity and more patients in my assignment. So I guess that's like where I'm at. The last week I worked Sunday and I did a loop shift, which you do half charge nurse and half stork. Stork nurse goes to pick up the babies who need to be brought up to the newborn neonatal ICU. We did not get any babies that needed to come up to our unit, but I did spend the shift with Stork, and she was absolutely amazing. She is so knowledgeable. She's been nursing for such a long time, so I did get to pick her brain the entire shift. But the second shift last week, it was just like I think one patient where I was able to chart and do skills, but we weren't able to see how I would do with 2 high acuity patients. And then the third shift last week was one super unstable patient where my nurse was doing most of the skills because it was just, I don't even know, I guess too high acuity for me. So it's like, it's either too high acuity, not high acuity enough. I don't know. I don't know where I'm at. All I know is that I feel like I need more experience with 3 patient assignments. So, yeah. I just got home from my second night shift, and I was with a different preceptor than what I was with last night, the previous night. But this preceptor was amazing. She was super encouraging and very nice. She was like, you tell me what it is that you need. You can delegate, you can pretend like I'm a PCT, like I'm a helper, like I'm an aide. I only had to ask her to feed maybe once or twice overnight. I had the same assignment that I did the previous night. It was pretty heavy, but the only thing that was different tonight was that the more attentive baby was a little bit more content, slept more. We still had another, one of my other babies was a little bit more fussy than he was last night, but he wasn't as bad as the original baby who was giving us problems the very first shift. So tonight is supposed to be my last shift on orientation. I'm supposed to be with a different preceptor tonight, one that I've been working with more recently on night shift. So I guess I can communicate to this preceptor that I am doing well on the low acuity side, and that there really isn't much more for me to see on the high acuity side. So yeah, and then the preceptor, my original night shift preceptor was here last night, but she didn't come over to get my folder to check off all of the tasks that I've done in my orientation folder, which was kind of a shock to me. I didn't even know that she was working that night until like towards the end of the shift when my 5th preceptor brought it up to my attention. So I'm not sure how that will go when I hand in my folder to my educator whenever that may be. But I'm super overall proud of myself with how I've been able to time manage. Unfortunately, on the less acuity side, there are way more tasks, and because we have to feed every baby, more so feed them like PO feed, it's a little bit more difficult to handle the cares, which I will be showing what cares are and how like a NICU shift is organized, so that this will make a little bit more sense. But this is more so to track like how my orientation is going and to just be open about it.
Okay, it is 93 degrees outside. It is so hot. Assalamu alaikum everybody. I am getting ready to put together my best friend's pinning ceremony gift. Unfortunately, I wasn't able to go because I worked the night before and I tried to wake up early enough, but I just wasn't able to go, unfortunately. And it broke my heart, especially after, because I was just, it's a very important moment once you finish nursing school to attend pinning ceremony. But anyways, what I got for her, it was kind of like an introduction to her graduation gift, because I want to get her a graduation gift as well, and it's coming in the mail. So I got her just literally some like smell good things. I got her a hair clip, and I wanted to get matching Stanley cups because everybody has Stanley cups as a nurse. I've never gotten one. I never caught up on the trend or jumped on that trend. But I wanted to get us matching ones, but unfortunately they didn't have the same color, and I really wanted the pink one, so I got a pink one, and I got her a white one. But I think that the white suits her best. And then I got her some roses, some pink roses, because I didn't get her a pink Stanley Cup. And then I got her this bag to put her little things in it. And I'm just so excited for her. Alhamdulillah, like, I'm so happy that she's finally done with nursing school. We finally have her back. You know, this is like consumerism at its finest. But it's always nice to just show appreciation and just showing somebody that you care and you acknowledge their accomplishments. I want to fill it with ice water. I think I'm more excited for this gift than she is, but we'll see. Words cannot express how excited I am. I am officially off orientation. My first shift is tomorrow night, and then I work Thursday, Friday. It is the 4th of July. It's not a Tuesday night, so it won't be like a pretty tasky night. However, if I break down what we do every single care time with each and individual patient slash baby, it is a lot of work. And yes, it is very overwhelming, because when you are fresh off of orientation, you do have a 3 baby assignment, sometimes even 4, depending on if we are like low staff. So if you do have a 3 baby assignment, every single 30 minutes when it starts to care time, you have to feed that baby, assess that baby, and then make sure that they are upright if they are on aspiration reflex precautions. So I'm definitely looking forward to seeing how I do on my very first shift on my own. I think that I was just getting over orientation period. I think I was just a little bit getting over orientation, because I had already had 9 preceptors. I was extended for an additional 3 weeks because my preceptors didn't feel that I was ready enough to come off orientation. They didn't feel like I saw enough high acuity patients, even though our census was low. So it was just, yes, it's a new specialty. However, I think once you understand the concept of being a nurse in that specific specialty, there's really nothing else that you can do or learn. You just have to figure it out on your own, if that makes sense. You have to figure out your routine, and then if you're not studying for a specialty that you absolutely love, like it's going to hurt you in the long run, your report for the oncoming nurse is not going to make sense when you're communicating with your MD, physician, resident, fellow, or APRN. It's not going to make any sense, because if you are trying to advocate for your patient and you don't even know like what their surgical history is, what their admitting diagnosis is, it's going to be very hard for you to properly assess that patient, know what to look out for that patient, and of course just advocate in general. I've also gotten to a point in nursing where I feel like advocating for your patient it's been so restricted. You know, you try to advocate for your patient, you try to say, hey, I don't think that this procedure is needed, or this procedure is needed, or they're not stable to go down for this exam or this, you know, scan, and you're not heard, which is painful, because you see the result of what happens to your patient when you're not heard. You know, there's been multiple instances in my previous unit or even this unit where I'm like, this doesn't feel right, or I'm questioning this order, and I'm just looked at like I'm a new grad, or I'm just a nurse, or I'm a new nurse and I don't know what I'm talking about. So it's just so important to not only know your specialty, but to know your patient as well. With that being said, I wanted to go over what it's like, even though I haven't had my first shift on my own, what it's like in our structured shift in the NICU. So I do have 2 different kinds of report sheets. We do have actually 3 different kinds on my unit. So we have, I will start with a 3 baby assignment. This is the layout that we have. So I can read off what's going on. It seems like a lot, and I think once I switched specialties, the one thing that was very difficult for me to understand was gestational age and corrected gestational age. So if you are interested in NICU, or if you are new to NICU, gestational age is the weeks of gestation that the baby or the infant was born. So for example, gestational age up here in this top, your left, I think, corner, gestational age would be, for example, 38 weeks. This baby was born 38 weeks gestation, but he was born 2 weeks ago. So now he's corrected to 40 weeks gestation. So that concept was so difficult for me to understand in the beginning, but once the repetition kept going, it was very easy for me to understand and identify, okay, this baby was born at 38 weeks, and now because this baby is 2 weeks old, that means the corrected gestational age is 40 weeks. And I'm not sure how far out we go for gestational weeks before we start like considering it like days or hours, because I've seen like 84 hours, or I've seen like 52 weeks if I'm not mistaken. I've seen like a variety of different things, but you can easily just look at the chart and it will calculate it for you. So you have gestational age, corrected gestational age, of course, like at the top you have patient and room for their name. Our babies go by like baby girl or baby boy, and then like I think the mom's last name, and then we have the mom's first name as well. And then we have their dosing weight. So dosing weight is already programmed in the computer in the chart. You copy it from the chart, and then you copy it, you put it on your report sheet just so it's a quick report. It's very important for you to do your safety checks when you come in at the beginning of the shift. You look in the chart, you see what the dosing weight is, and then on the monitor in the patient's room, we have like a laminated code sheet which has their dosing weight. So with your safety checks, when you're checking your bag, your mask, if you have a trach, your trach supplies, and your suction, always make sure that you look at your dosing weight, and then you read off the MRN of the baby, the MRN on that code sheet, just to make sure that everything matches. It's super important because in the event of an emergency, you want to make sure that you have your suction, you have your bag and mask, and then you have the right baby. Your current weight. So we do sometimes daily weights. I think everybody gets daily weights, which is done on night shift. So once you weigh the baby, you'll get that current weight, and then you can calculate how much the baby gained or lost. Another thing that was kind of complicated for me to like switch and learn to or adjust to was grams and kilograms. Calculating the loss and gain wasn't something that I asked. I just figured that once I knew how to calculate it, it'll just click in my brain. So let's say I do have a baby and I came in and it was 1.44 kilograms. So I'll try to convert that in my brain to grams. So you'll move the decimal over, convert it to 1440 grams, and then let's say the baby weighed 1500 grams or 1.5 kilograms my shift, then it was a gain of 60. So it's just something that it's new and something that I never had to do in adults. You just have to get, used to it. That wasn't anything that I had to look up. It was just something that, okay, I see where I moved the decimal point and I can do it in my brain now. I pull out my calculator once in a while to make sure that I calculated correctly, like what was the gain and what was the loss. We have code status, NRP, and then you have PALS. DNR, difficult airway, isolation, diagnosis and history. So for diagnosis and history, at a certain point you don't really need the mom's like health history, like if she was GBS positive or if it was a spontaneous vaginal or a cesarean. In the event that you do have a patient who's like chronic respiratory, it could be pertinent to mention what happened in like birth, but most of these babies are just like, they're just born like that. They just have this disorder. They just have this defect that, you can't really explain it. Like they were just born, nothing happened at birth. Diagnosis and history, this is where you can go over like surgeries, dates are so important. They're always going to ask you, like in report from another nurse, they're always going to ask you, when was this done, when was the scan done, the surgery, when do they plan on doing the next step. And then you can cross off, I don't really use this, but cross off like when you do your safety check. I remember when I was getting report like in the adult ICU, I would take a blank piece of paper and I think I have a video, and I would just turn a blank sheet of paper into this amazing report. I remember somebody who was very close to me on my old unit, he complimented how great of a job I turned a piece of paper into a report sheet, and I miss that. One thing that's so sad, working in a hospital is like a toxic relationship. You feel like you're underappreciated, but then you go to a new hospital and you're like, wow, I really miss this. So it's like that compare and contrast that you have internally whenever you do leave a hospital. But if, like, let's say you're a traveler, or you're just like in a hospital like just for a year, and then you're spreading your wings to another hospital, it can be hard to get attached. Or if you get attached really quickly, of course. But for me, at least, that was my very first hospital. I mean, like, I was literally raised there as who I am today. So it's very hard to compare and contrast, and I miss it. But anyways, going back to our report sheet, I brought up my old report sheet because we go by systems just like we go by systems here. The only difference is issues and concerns. I mean, typically everybody had like the same structure. You know, like they have like identify the patient, and then you had like your admitting diagnosis or health history or whatever. So right here we have issues and concerns. So if this baby has respiratory issues, or they have acid reflux, or like GI, anything GI, just what is the main goal of this baby? Billy, phototherapy, we're gonna put it on the top, the issues and concerns. And then we go down to thermoregulation and skin. So the radiant warmer, where the baby is like encapsulated in this little box, and we could do like humidity to make obviously like kind of like a sauna in there. You could do humidity, or you can just do heat. Using that machine is low-key intimidating, and I'm still getting used to using it. I haven't really had like consistent use of the isolette is what it's called. So that's one of the things that I do have to get used to. I do know how to like weigh a baby on it and just like do like basic things, but it's gonna take me some time to get used to like the majority of the equipment. Thermoregulation and skin. So the radiant warmer, if the baby is in an isolette, you're gonna write down like what the temperature of the bed is set to, and then what the humidity is set to if they are on humidity. So that's typically an order. It has to be ordered in the chart for the baby, so you know like what we're supposed to keep this baby at temperature wise. Another thing that was kind of like I had to adjust to was Celsius. So we use Celsius to check our baby's temperature. So 36.5 to 37.5 is our range. Skin, if there's anything going on with the baby's skin, like if there's any marks, if there's any like birthmarks, bruises, we talk about sometimes, not the fontanelles necessarily, but we talk about if there was a previous cephalohematoma or a hematoma currently, and if there's a diaper rash, and then what kind of cream we're using. Neurodevelopment, so we do like cranial ultrasound, we do like hearing tests, and then we do like eye exams as well. One thing that I learned, respiratory and eyes. So oxygen, of course, is a drug, and it can actually affect a baby's eyes, so it's very important to get their eyes checked. Respiratory, ventilation, O2, obviously you're going to talk about a little bit more in depth of like the history of how the baby's doing respiratory wise, their current ventilation, if they're on room air, if they're on bubble CPAP, my favorite, so cute. And then like what the overall goal is for O2, what the plan is for extubation, for just weaning off that CPAP or that high flow, whatever it is. Cardiac, so a lot of defects like PDA, PFO, just something that you have to practice on. I know cardiac in nursing school is like the worst subject to learn, but if you're breezing through pediatrics, the cardiac is like, it's so difficult. Like you literally memorize the cardiac defects of an infant and then you just forget it. So you have to brush up on that. Echoes are very big. If the baby had an echo, it's very important to identify what was found when they had the echo, and if they are planning on following up, if they have cardiology on board. If we don't do a echo, we do I want to say CCHD. So CCHD is when you put like a pulse ox on the preductal and postductal, and you try to make sure that there's not a certain different percentage in what the oxygen saturation is. It's something we just got to study. FENGIGU. So this is what the baby is eating, what nipple they're using, breast milk, donor breast milk, mom's milk, any kind of special formula. And then we have girth. So we do measure the baby's belly twice a shift. And then labs and procedures. So whatever labs you are planning on doing that shift, or if they have scheduled weekly labs. On the back side, we do have like their access. So if they have a PIC, if they have an IV, cap change. So in this hospital, we do cap changes as a sterile procedure, which was never done religiously like that in my old hospital for adults. But I think that it tremendously does help probably with CLABSIs. And then you have like your times. So a baby can be a care time scheduled for 8, 8:30, or 9 o'clock. If you have 3 babies and you have 30 minutes to do your cares, your assessment, and your feed in 30 minutes, it can be very difficult to work on time management or just to perfect time management in general. So that is one thing that I'm really excited to just overcome, especially starting on Thursday. I'm very excited to see how it is that I do my very first shift. It's going to be super overwhelming, but Tuesdays are days that we do like head circumference and length. Luckily, since I'm working Thursday and Friday, I don't have to do any of that. I just have to focus on my cares, labs, and assessment, and I'm just very excited, and I really hope that I'm an amazing NICU nurse. And I'm really excited that you guys, however many are following, are still watching my journey, and I just really appreciate everybody's support. So thank you so much, and I will catch you in the next video.